Hi everyone, this talk is on traumatic brain injury with the special thanks to Joanne O'Keefe, who did this lecture last year and gave some slides. So these are the session objectives. We want to be able to describe the leading causes of traumatic brain injury in the age groups that are predominantly affected. You want to be able to know the definition of and danger signs indicating a concussion may have occurred. We want to know the common symptoms of traumatic brain injury, the different types and mechanisms of injury in each of the following: concussion, contusion, diffuse axonal injury, coup-contra-coup injury, chronic traumatic encephalopathy, and know something about dementia pugilistica. And then, of course, we want to know a little bit more detail about chronic traumatic encephalopathy. This slide is a comparison of the annual incidence of various medical problems, and what you can see is that traumatic brain injury is much greater, more common than all of the others combined. Each year, an estimated 1.5 to 1.7 million people sustain a traumatic brain injury. Here are the rates of TBI-related emergency department visits, and what you can see is that although death from traumatic brain injury may be declining, there are a lot of emergency room visits that are happening and hospitalizations for this particular problem. More than 50,000 people die every year as a result of traumatic brain injury, and men are 1.5 times as likely as women to sustain a TBI. Approximately 5.3 million Americans are living today with a TBI-related disability, and more than 30,000 children each year have lifelong disabilities as a result of traumatic brain injury. This is the etiology of traumatic brain injury by age. So what you can see is that some of the etiologies do vary quite a bit depending on how old the individual is. In our older population, more than 60 years old, falls are the most likely cause of traumatic brain injury. Motor vehicle accidents are quite common across all age groups, as are bicycle accidents and motorcycle crashes. Assault from somebody else is going to be more likely in the younger age groups, and self-harm will vary but will peak in the 30s to 50s. Again, falls are the leading cause of traumatic brain injury, and the number of fall-related TBIs among adults age 75 or older has been increasing. People age 75 and older have the highest rate of hospitalizations or death from traumatic brain injury. Motor vehicle crashes result in the largest percentage of TBI-related deaths, about 32% among all age groups. Shaken baby syndrome is a form of abusive head trauma and is an inflicted traumatic brain injury and is a leading cause of child maltreatment deaths in the U.S. This particular syndrome is caused when a baby, an infant, is shaken hard enough to cause a abnormality in the brain, and we'll go through some of those abnormalities. This particular abnormality, when it occurs in infancy, will prevent the normal development of the brain and can actually lead to death in infancy. These are the common symptoms of a traumatic brain injury. There are several physical symptoms that we'll see in somebody with TBI. Patients can have headaches, nausea or vomiting, dizziness or balance problems, visual issues or sensitivity to light, sensitivity to noise, and numbness or tingling in the extremities. Cognitively, these patients will describe feeling foggy or slowed down. They may feel dazed or stunned. They'll have difficulty concentrating and remembering. They have problems with forgetting or feeling confused about recent events, repeating questions, or in children, they may have changes in school performance. Emotional symptoms are common after TBI. These patients become irritable, sad, or depressed. They can be nervous and in general feel more emotional than they did prior to the injury. They may develop some apathy or lose interest in their favorite activities. Finally, sleep and energy can change after a TBI. These patients will describe feeling fatigued or drowsy. They tend to sleep more or less than usual and will have trouble falling asleep or staying asleep. Let's go through some types of traumatic brain injury. We're going to cover concussion, contusion, subdural hematoma, epidural hematoma, subarachnoid hemorrhage, which should be a review, and diffuse axonal injury. Concussion is a type of traumatic brain injury caused by a bump, blow, or jolt to the head. Now, this can include injury from contact sports, which we'll talk more about in a few slides. Concussion can also occur from a fall or a blow to the body that causes the head and brain to move quickly back and forth. Healthcare professionals may describe a concussion as a mild traumatic brain injury because concussions are usually not life-threatening. However, some patients will have long-term effects from a concussion. There are several danger signs of a concussion that will require more immediate medical care. If the patient has a headache that gets worse and does not go away, if the patient has associated weakness, numbness, or decreased coordination, if they have repeated vomiting or nausea, slurred speech, if they become drowsy, have an abnormal pupil such as a dilated pupil or cranial nerve 3 palsy, if they have convulsions or seizures, if they are unable to recognize people or places, if they become confused or restless or agitated, if there's any unusual behavior, or if there's a loss of consciousness, these patients should be seriously evaluated and monitored. Now, what we're seeing here is the danger signs of a concussion are frequently going to localize to a cortical side effect, with the exception of the dilated pupil or third nerve palsy. In that case, we're concerned that the patient actually has increased intracranial pressure and may be at risk to herniate. The danger signs for concussion in children will look somewhat different. Although they may have some of the signs that we would see in an adult, children cannot frequently give us a verbal history, and so you'd be looking for constant crying or an inability to be consoled by the parent. Children who have concussion may also refuse or be unwilling to nurse or eat. Cerebral contusion is another traumatic brain injury and occurs in about 20 to 30% of severe traumatic brain injury. It can be associated with multiple microhemorrhages within the brain, or you can have numerous small contusions from broken capillaries that occur in the gray matter under the cortex. And these can be multiple petechial hemorrhages or multifocal hemorrhagic contusions. These abnormalities occur under the site of impact, especially in brain regions near the sharp ridges on the inside of the skull, so the frontal lobes or the temporal lobes. These patients will have attention, emotional, and memory problems associated with damage to the frontal and temporal lobes and are common in head trauma survivors. Let's look at what this looks like. So this is an axial CT scan without contrast. And what you can see in circles with arrows and stars are the abnormalities of this patient who has suffered frontal lobe contusions. In fact, we call these the frontal pole contusion. So what happened with this particular patient is that they were in a car accident and they had an injury where the front of the brain was smashed against the cranium. When that happened, there was damage to the frontal lobes bilaterally. So this contusion shows evidence of hemorrhage within the injury and surrounding edema, which is in the circle on the left. There's also a mass effect on the anterior horns of the lateral ventricles, and you can see decreased ventricular volume. The arrows are actually really not pointing to the ventricles here, they're pointing to the blood and edema. When we describe an injury, you will frequently hear the terms coup or contre coup. Coup injury occurs under the impact with an object. So in this particular picture, the coup injury would occur with a blow to the front part of the head. And this would be followed by a contusion or other abnormality in the frontal lobes. A contre coup injury occurs on the side opposite the area that was impacted. So what would happen in a contre coup injury is that the patient would be hit in the front of the head with a blow to the front of the head, but the injury actually occurs here. And the reason why this happens is because of inertia. So when you hit the front of the head is going to quickly move backwards. And it's that inertia of the brain moving backwards where it's hit in the back of the skull that's causing the injury to the occipital lobes. So as described on this slide, the brain keeps moving after the skull is stopped by a fixed object, or when the brain remains still after the skull is accelerated by an impact with a moving object, such as a football or a soccer ball. Frontal, occipital, and temporal poles are the most common sites of injury, and it makes sense given what we know about the locations of the bones and the most likely place of impact. The subdural and epidural hematomas are review as they were recovered by pathology, but I brought them back today to make sure that these concepts are reinforced. A subdural hematoma occurs when there's a rupture of the bridging veins around the brain. This can occur acutely with trauma or chronically in the elderly, such as after a fall. We will also see subdural hematomas in the shaken baby syndrome. This particular hematoma looks like a crescent-shaped hemorrhage in the brain scan. And so what you can see here is it almost looks like a backward crescent moon. Now, the thing about the subdural hematoma is that it will cross suture lines. So we're seeing it all the way around the outside of the brain or the cortex. We remember that acute blood is hyperdense on our CT scan and chronic blood is hypodense on our CT scan. However, in this image, we're looking at an MRI. An 82-year-old man developed progressive confusion and weakness of the right arm and leg after a fall, and this is his subsequent CT scan. The next hematoma we're going to look at is an epidural hematoma, and this occurs from rupture of an artery, usually from a skull fracture. The most common artery that is ruptured is a middle meningeal artery, and this particular type of hematoma causes a biconvex or lentiform shape abnormality of hyperdense blood. In this particular scan, you can see this white area here, and it almost looks like a lens. So if you kind of think about what a contact lens looks like or the lens of the eye looks like, it's kind of what we call this biconvex appearance. Now these hematomas do not cross the suture lines, and so they're going to be much more focal than the patients who have a subdural hematoma. Now, because these are much more focal and they don't cross the suture lines, there's less room for them to move. And for this reason, these patients may herniate faster than patients who have a subdural hematoma. These patients usually at the time of injury will be lucid, and then as they herniate, they become less and less lucid. Subdural hematomas can be chronic, and the reason why they can be chronic is because when you rip those bridging veins, patients who are elderly will have general volume loss, and so they have room to move when you have accumulation of blood within the skull. Epidural hematomas do not behave this way. When you rupture a middle meningeal artery, you're going to have quick, rapid flow of blood into the cranial cavity. You're going to have movement of the brain outside of that area that the blood is in. The blood is going to be essentially pushing that brain away. And because of this, you're going to be at much faster risk of herniation. You want to be able to distinguish the subdurals and the epidural hematomas for your step exam. This slide is a review for subarachnoid hemorrhage, and as we remember, subarachnoid hemorrhage occurs when blood spreads throughout the cisterns and fissures surrounding the brain in the subarachnoid space. This particular scan is from a 51-year-old man who sustained a subarachnoid hemorrhage following a motor vehicle accident. Now, as you recall, we learned about subarachnoid hemorrhages because of aneurysm rupture, but you can get subarachnoid blood from other causes, including trauma. As we recall, blood is bright acutely on the CT scan, and we can see it here. Now, this is a reminder that when you have a traumatic brain injury, you can have multiple types of hemorrhages in the same patient. This is an axial CT scan without contrast, and we see multiple types of hemorrhage in this scan. This is a 45-year-old woman who was brought to the emergency department in a coma following a head injury sustained during a motor vehicle accident. On this scan, we can see 3 different types of hemorrhage. In the first area, we can see an intraparenchymal hemorrhage from a contusion in the temporal lobe. Again, the blood is white. The second injury we see is a subdural hematoma. And although this is a smaller subdural than the one I just showed you, you can see that it's crossing suture lines. Finally, we see subarachnoid blood or subarachnoid hemorrhage, which has now moved into the subarachnoid space between the pia and arachnoid and is encasing the brainstem area. And this may be why the patient has lost consciousness. Let's move now into diffuse axonal injury. This particular type of injury you may have not heard of before, and it's the result of traumatic shearing forces that occur when the head is rapidly accelerated or decelerated, as may occur in auto accidents or other traumas. Usually this results from rotational forces or severe deceleration. It can occur in shaken baby syndrome or in older children as well. The major cause of damage here is disruption of the axon by the shearing injury. So brain regions of differing densities tend to slide over one another. They stretch the axons, especially at the junctions between the white and gray matter, and they are injured. This particular slide shows a picture of what this looks like. So essentially you can see at this gray-white junction, you see direct injury from the sudden acceleration, deceleration, and you can see the damage or axonal shearing. Diffuse axonal injury, like the other injuries I've already discussed, can be very difficult to see on imaging. On a T1 weighted MRI, it may be hard to see any abnormality at all. And over here on the right side is a T1 weighted MRI, so you see the CSF is dark. We actually don't see any abnormalities at the gray-white junction except for these small little bright spots, and these are actually blood. And you can see it again on this side. Sometimes we may see a loss of the gray-white differentiation on an MRI scan, but in general, we are not going to see an impressive scan like we'll see with the other hematomas. Let me just comment also that frequently concussions will have normal imaging as well. I just want to comment that some patients with traumatic brain injury will have seizures within the first week of their injury due to anoxia, hemorrhage, or other brain damage. So frequently we will give anti-seizure medications in the hospital at the time of the traumatic brain injury as a preventive measure. More serious injuries can result from recurring injuries, and this is called post-traumatic epilepsy. We'll talk more about epilepsy when we do the case on Monday. Recurrent traumatic brain injury has become much more likely to be heard about in the news. This is also called second impact syndrome, and it occurs in professional boxers, football players, or others. So let's talk a little bit about these diseases. A traumatic brain injury can increase the risk of neurodegenerative diseases, including Alzheimer's disease, which we learned about already, Parkinson's disease, and a disease called dementia pugilistica. Dementia pugilistica is most often associated with repetitive blows to the head in career boxing, and this leads to dementia and Parkinson's symptoms. Many of you may remember that Muhammad Ali had Parkinson's disease, and he may be the most well-known character who had dementia pugilistica. Now, because of the injuries that occur in boxing, the American Academy of Neurology has never endorsed boxing as a sport, and in fact has been very much against boxing because the whole point is to cause head injury, and we know that this leads to degenerative brain diseases in addition to other problems. Most recently, the American Academy of Neurology has also found that football playing is problematic too, and let's talk about that next. Chronic traumatic encephalopathy, or CTE, is a progressive neurodegenerative disease that is marked by the accumulation of hyperphosphorylated tau. On the right side, we can see on pathology a normal brain and then a brain of a patient who has CTE. And what you can see is that it really is smaller than it should be, so there's general overall volume loss. On the bottom right side of the slide, with the arrows, we can see evidence of staining of hyperphosphorylated tau. This is all abnormal and should not be present, especially in individuals of the age that we've had autopsies on. This particular disease is associated with aggression, dementia, erratic behavior, suicide, apathy, sleep, and balance problems. And the reason it came to the attention is that frequently these symptoms will occur much earlier than you would expect for typical dementing disorders. There has also been widespread national attention because the suicide rate of NFL players is higher than the general population, and it appears that CTE is part of the reason for this. Now, CTE can occur without a history of known concussion in individuals, but NFL players are especially high risk for this disease, although other contact sport players are also known to develop CTE. I just want to review this paper that came out last year that really changed our thinking in neurology about CTE. And this was a study looking at clinical and pathological findings of people who played American football. They looked at 202 American football players whose brains were donated for research. CTE was diagnosed in 177 of 202 of these individuals, with a mean year of football play of 15 years. What was striking about this study is that they had brains from people who'd only played football prior to high school, college, and then NFL. And what we know now is that the risk of CTE goes up depending on the level of play. So in the two brains they got from patients who played only up until high school, but not in high school, there was no CTE. Recognizing only two brains is probably not enough to make a conclusion. Of the high school brains they had, 3 of the 14 had evidence of CTE. These are individuals who never played past high school, and this is 20% of their total sample. Of individuals who played in college, 91% of them had evidence of CTE, And in the NFL players, 99% of them, 110 out of 111, had CTE. Now, of the patients who had clinical findings of mild CTE only, 96% of them had behavioral or mood symptoms. 85% of them had cognitive symptoms such as memory loss, and 33% of them met criteria for dementia. Patients who have pathological findings of severe CTE, 85% of them will have dementia. And again, the reason why this is striking is because the dementia comes on much, much earlier, decades earlier than we would typically expect for Alzheimer's disease. So I am telling you about this study because although many of us may have been fans of football earlier in our careers, it appears now that football is actually causing pretty severe brain injury. And because of this, the field of football is changing as well. So even in the suburbs of Chicago, some high schools are shutting down their football programs because parents are no longer allowing their children to play. This is likely to result in a change in football playing where maybe the rules will be changed or some other way to improve the safety of the players should be occurring. Let's talk about some other diseases that are associated with traumatic brain injury. And it appears that other neurodegenerative diseases, such as Alzheimer's disease and dementia pugilistica, are again caused from traumatic brain injury. I mentioned that repetitive TBI in our boxers is related to this dementia pugilistica, and pathologically we see neurofibrillary tangles like we would see in Alzheimer's disease that contain abnormal tau. In severe traumatic brain injury, especially in individuals who have an ApoE allele, this will increase the likelihood they will develop dementia and Alzheimer's disease with confirmatory pathology. So although we don't necessarily consider that there are many risk factors for Alzheimer's disease, and it is a common problem as individuals get older, it does appear that traumatic brain injury can tip the scales for people who are at risk. The initial treatment of traumatic brain injury is to manage increased intracranial pressure, because if this does not occur, the patient will acutely decompensate, herniate, and die. Many patients will need a device placed surgically into the cranial cavity to monitor the elevated intracranial pressure. Now, if in the session activities for one of our prior cases, we talk through some of the ways that we would try to lower intracranial pressure. We can intubate the patient or provide mechanical ventilation to support breathing. If signs of herniation exist, we can give mannitol or another hyperosmolar diuretic to draw fluid out of the brain. If there's bleeding present in the cranial cavity, we can do surgical decompression, removal, or damage. And in severe cases, you may need to remove the cranium to allow to make room for the brain to swell. Hypothermia can reduce the oxygen demands of the brain, so we'll cool patients down. We will put the patients on paralytics and sedatives in a drug-induced coma in order to minimize agitation or secondary injury. Some patients will have a ventriculostomy or an external drain placed. And in an open head injury, skull fractures may need to be repaired and damaged tissue removed. In patients who have increased intracranial pressure, the head-up position needs to be occurring at all times, so you essentially elevate the head of the bed. Now, in patients who are medically stable, we will provide inpatient and outpatient rehabilitation. Many patients post-traumatic brain injury are going to have disability, chronic disability. So we want to mitigate that by doing therapy to get them back as close as we can to their baseline. Many of these patients will be treated by physical medicine and rehab doctors or physiatrists. Occupational therapy, speech therapy, and physical therapy are mainstay treatments. And many patients will need cognitive therapies and family counseling. This is my last slide, and this is my goodbye to all of you. This is the last lecture you will be hearing from me. And my last encounter with you guys is going to be on Monday with the epilepsy case. So I just wanted to say a few words before I leave you and you go on to learn psychiatry. So with a summary of our course, I just want to tell you that you guys have done a great job learning this material. I think the small group format has worked very well for neurology and neuroscience, even though you may have found it very challenging. We had 13 volunteer neurologists and 1 volunteer neurosurgeon who helped us teach, and I will be thanking each of them individually. We had 8 residents and we had 5 live patients, all of whom we are thanking as well. So I just want to say it's been an honor to teach you guys. You have a fantastic class, and I just have a few words of wisdom. The first is that we have covered everything in this block that you will need for the STEP exam with the exception of neuro-oncology. And it is likely you'll need to go back and study that. If they don't include a case next year, you'll want to make sure you pull out the neuro-oncology materials and study that for step 1. I want to tell everybody that you need to take care of yourself. So doctors don't tend to take care of themselves, and although your generation might do better than ours, you want to make sure you remember that as you go through this process. You want to make sure you're flexible. A lot of stuff is going to happen. You're going to see a lot of very interesting things on the ward, some things that may be emotionally challenging, but you need to just go with the flow, learn as much as you can, and try to be the best doctor that you can be. I want to remind you that everything you should do with moderation, except for cocaine, which, as you know, I've said before, is really bad for your brain, so don't be doing any cocaine. And last, I just want to tell you, live in the moment. So this is a journey. You guys have done a fantastic job getting into medical school. It is really the hardest part, if you can believe it, of the whole process. And some of these memories you're creating in medical school are going to stay with you forever. Some of the friends that you meet in medical school will stay with you forever, and that is the same for residency. So good luck to all of you. I hope that some of you become my colleagues in neurology. If not, I hope you become my good colleagues in other specialties and that we can rely on each other as we need each other for patient care. Good luck. Take care.